Hi, this is Dr. Rogan from RBK Pediatrics. I'm here with Dr. Rao, who you may have seen in our office this past month. He's going to talk to us today about acute abdominal pain that's seen in a pediatric urgent care setting, things that he had seen over the month, and what a parent needs to know. So take it away, Dr. Rao.
All right. So like Dr. Oga said, we're going to talk about what your child's abdominal pain might mean. And here's just a list of common causes of abdominal pain in kids. So starting off, we have, I guess, the big gun, appendicitis. It's arguably one of the most severe conditions we're going to discuss today. And then we have gastroenteritis, food poisoning, gastritis, GERD or acid reflux, and inflammatory bowel disease, irritable bowel disease, chronic constipation, and UTIs, which are also a source of abdominal pain in kids. And let's get into the first topic, appendicitis. So, what is it? It's essentially an infection of the digestive tract in the portion of bowel after the small intestine where it connects with the large intestine. And it can be caused by a blockage in the lining of the appendix as well, which can also result in that area getting inflamed and causing pain. And here's just a diagram here of the appendix showing you where it is. And if we move on here, what should parents look for in a child that could be suspected of having appendicitis? So, usually the pain presents as right lower abdominal pain, pain around the belly button that can kind of shift over to the right side. And they could also have fever, nausea, and vomiting, loss of appetite, bloating and constipation, or flatulence, also known as passing gas. And they can also have altered bowel movements and a host of other symptoms, but these are usually the most common. And in terms of what we look at in the healthcare setting and what we do to treat it, generally we do a physical exam and check for rebound tenderness, which is pain when we press and immediately release pressure from the belly. And there's a few physical exam signs that I'm going to get into immediately afterwards. And generally, they'll do some kind of scan, like a CT scan or an ultrasound, some blood work, and the end ultimate treatment is surgically removing the appendix, also known as an appendectomy, and antibiotics. So, to get into some of these diagnostic tools that we use, we look at McBurney's point, which is two-thirds of the distance from the navel to the ASIS, which is part of the pelvis. And that's usually a location where the pain's at the maximum intensity. And like we discussed, fever, constipation, diarrhea, nausea, and vomiting, and the rebound tenderness and other physical exam findings. There's psoas sign, an obturator sign, which you can see there as well on the right. And in terms of the lab work that we do, generally patients will have a high white blood cell count and inflammatory proteins. And like we said, we can do a CAT scan and ultrasound as well. So those are some things you can expect if your child is uh, suspected of having appendicitis. And next is gastroenteritis. And this is essentially inflammation of the stomach and intestinal lining. It occurs about 1 to 2 days after exposure to uh, whatever pathogen or irritant that's causing it. And usually it's caused can be caused by virus, gut bacteria, parasites, chemicals, or food. They can all cause it as well. And here you see a diagram showing the stomach and its position in relation to the small intestine and the large intestine, essentially showing that all of those structures are connected as the whole of the gastrointestinal system. And to get into what patients should look for here, your kid might not be with his face in the toilet, but he is going to be pretty sick. It might have nausea and vomiting, fever, diarrhea, malaise, which is a general feeling of feeling ill or sick. Some cases they might have blood or mucus streaked stools, and it lasts a few days. But if your child is persistently sick or has a long-lasting fever, then you should see a healthcare provider immediately because there could be underlying issues that could be going on that are worsening their condition. And for diagnosis and treatment, generally, similar to appendicitis, we do blood work, stool tests, fluids, and rest is really important here. Supportive treatment here is key to improving the symptoms. And if an bacterial infection or parasitic infection is suspected, we'll treat that with medication accordingly with antibiotics or antiparasitics. And you want to avoid giving your kid anything that would prevent them from uh, the diarrhea or nausea. I know it sounds counterintuitive, but um, the diarrhea and vomiting, if it's caused by a pathogen like bacteria or virus, you want that to exit the GI system, and giving them something that prevents it from leaving can further worsen their symptoms. So that's something that might be commonly uh, I guess, mistakenly treated by a patient's parents, but it's something to keep in mind. So food poisoning is also pretty similar to gastroenteritis, but the onset of symptoms is much more rapid. It's usually a few hours after ingestion. It's caused by eating stuff that's been contaminated by infectious organisms. Usually it's bacterial. Here, I have a picture of a family at a picnic because a lot of times um, classically, it's picnic has a lot of bacterial contamination that can occur when you put food on the ground and stuff. It can put it at higher risk of being contaminated. And what should parents look for here? Usually, food poisoning is pretty mild and resolves quickly on its own as soon as the pathogens leave the system. It starts within a few hours of ingestion and resolves within 1 day or so, and can last longer sometimes, but generally this is the most common presentation. And you're probably going to see some loose stools, nausea, vomiting, a little bit of fever, and abdominal pain. Um, and if we move on to diagnosis and treatment, generally we do clinical diagnosis, but we can also order some labs and do some stool testing if we think that's appropriate. Uh, Fluids and rest are really important, just like with gastroenteritis. You want to make sure that you are providing good supportive care so that the child gets good recovery. And just like with gastroenteritis, again, antibiotics or antiparasitics or whatever medications are appropriate to treating the pathogens that are involved. And with worsening symptoms or prolonged and recurrent symptoms, they once again might require a visit to a specialist for further care. And next, we're going to talk about gastritis. And gastritis is inflammation of the stomach lining. It's usually caused by the H. pylori bacteria. And if untreated, it can result in ulcers and increase the risk of stomach cancer. And right here, I have a picture of what a healthy stomach lining looks like and what a stomach lining in a patient who suffers from gastritis might look like. And here, just a quick overview of what patients should look for. It presents as burning upper abdominal pain, and patients might also have reflux or they might spit up food, and generally can have some sensations of nausea and vomiting, and your child might feel like they feel satiated earlier. They might be eating smaller portions um, just because of the reflux and their stomach feeling like it's full when it's really uh, just a symptom of the gastritis. And here on this picture, I just have an overview, same symptoms that we just discussed. They might also have some bloating and hiccups, as well as recurrent upset stomach, and they might belch um, due to the nausea and vomiting symptoms. So, in terms of diagnosis and treatment for gastritis, we can do a stool test and a breath test for H. pylori. to make sure and see if that's the causing organism. And in severe cases, they may do an endoscopy to take a look at the esophagus and stomach lining, and an X-ray or barium swallow, where your child might be requested to swallow a dye that will pop up on X-ray, just so that we can take a look at the esophagus and the stomach in a different way. And if we do suspect bacterial infection like H. pylori, then we'll give antibiotics. And we also may treat the stomach acid to stabilize it. And that can be done with stuff like proton pump inhibitors, which are essentially an anti-acidic medication. And otherwise, generally treat with fluids, rest. You want to avoid acidic foods, and also you want to avoid giving your child too many non-steroidal anti-inflammatory drugs. And these can be things like ibuprofen, like Motrin, Aleve, because those can worsen symptoms of gastritis and also lead to ulcers and a host of other gastrointestinal issues. And right here, I just have a picture showing what H. pylori might look like under the microscope on the top there. And below that, I have an X-ray image of a barium swallow study of the stomach that was done, just so that you can see what it might look like. And now we're going to talk about gastroesophageal reflux disease. And what is GERD? So it's essentially a reflux of the gastric contents after eating, and it usually comes up with the acid that's in the stomach. So it can really inflame that esophagus. It's common in infants as well as older children. And here I just have a picture of acid coming up the esophagus. So you can see that a relaxed esophagus where it meets the stomach can kind of cause backflow. And what should parents look for in GERD? Generally, you may see burning pain in the stomach or the throat, along the path of the esophagus. Uh, your kid might say that they taste sour or bitter food. It's exacerbated by eating acidic, spicy, and fatty foods, alcohol, or eating close to bedtime. So if you notice that after eating these kinds of foods or these kinds of behavioral patterns, then it's reasonable to suspect that your child might have GERD. And it can also cause a nighttime cough. And that's a less common symptom of it, but it can present similar to nighttime asthma almost, due to the reflux of the food and acid. And it's common in infants as well, like we talked about. Um, and it's important to make sure that they get out burps and have positional therapy to help with that. So here's a little overview on diagnosis and treatment. It's usually a clinical diagnosis, but the gold standard, which is very rarely done unless atypical symptoms are presenting, is a 24-hour gastric pH study. And just like with gastritis, we can also do a barium swallow to look at the esophagus and the stomach with a contrast. And in thriving infants, usually, like we said earlier, you can use positioning therapy and burping to see if that can improve their symptoms, and making sure that they stay upright for 20 to 30 minutes even after feeding can really help that. And in older kids, if it's symptoms that are refractory to over-the-counter acid blockers like Tums or Mylanta, then we can try proton pump inhibitors, which are a little bit stronger, like omeprazole. And if that's even refractory to being treated with something like that, then it may require an endoscopy. And the most severe cases of GERD generally are treated surgically. And it's usually not in children, it's usually in older adults who have had long lasting symptoms. It's a surgical procedure called a Nissen funduplication. But that's a last case sort of treatment, mainly in adults.
In children, you usually see this in the ones that have like cerebral palsy, children with cerebral palsy.
Mhm.
this fundoplication because they get a lot of reflux. It goes up and then it goes and irritates the airway. Then they get the wheezing, and they're not too mobile because they're in a wheelchair.
Yep.
So that's why they'll do that in the cerebral palsy. But a regular healthy child, they won't do that.
Mm. And I also have just a few pictures of some anti-acid reflux medications. Mylanta is commonly given to kids. Um, Pepsid is famotidine, which is can be given as well, and Prilosec, which is the proton pump inhibitor, known as omeprazole. And we can move on to our next conditions we're going to talk about. So these two, because of the similar name, it might be easy to confuse them. Irritable bowel syndrome and inflammatory bowel disease. So irritable bowel syndrome is abbreviated as IBS, and inflammatory bowel disease is abbreviated as IBD. So IBS rarely requires hospitalization or surgery, and symptoms usually improve after your child might have a bowel movement and might feel a little bit more comfortable after that. And it usually presents as bloating and gas, whereas with inflammatory bowel disease, uh, presents a little bit more severe and might present with bloody stools, which you usually wouldn't see with IBS. And your child might be fatigued, have a reduced appetite, and unintended weight loss. And with both of them, you'll see abdominal pain, cramping, and bowel movement changes. Within IBD, there's also two subcategories. There is Crohn's disease, which involves multiple lesions throughout the gastrointestinal tract, and there's no continuity with these lesions, meaning you might have one lesion higher up on your GI tract and one lesion that's closer to the large intestine. So it can present that way, and it's usually an inflammation of the entire thickness of the bowel wall with Crohn's disease. And with ulcerative colitis, it's generally closer to the rectum, so it's closer to the end of the GI tract, and it tends to be bloody, unlike Crohn's disease, which tends to have non-bloody symptoms. But both of them cause severe damage to the intestines, and they can increase your risk for colon cancer. It's mainly associated with ulcerative colitis rather than Crohn's, but both can have that link. Um, and we can look at the diagnosis and treatment, so patients and parents are aware of that as well. So with IBS, it's generally a clinical diagnosis, and you want to exclude things like Crohn's and ulcerative colitis and some of the other things that we discussed so far in this presentation. And it rarely requires invasive procedures to diagnose, like a colonoscopy, although they might want to do it to rule out something like inflammatory bowel disease. For treatment, generally starting your child on fiber supplementation and a low FODMAP diet, which we'll get into in just a second, uh, and diet that can make some modifications to lactose can really help their symptoms. And with IBD, we generally do blood work, stool studies, may require a colonoscopy or some other screening protocols, such as an endoscopy, as a tool. And we may decide to give anti-inflammatory drugs, immunosuppressants, and surgery. It would be the ultimate like refractory procedure that would be performed. Generally, it's done for ulcerative colitis, and it's a proctocolectomy where the end of the colon is removed to prevent any risk of further inflammation or reduce the risk of colon cancer as well. And so this is the low FODMAP diet. So essentially, you want to consume more vegetables like lettuce, carrots, cucumbers, berries, eat lean meats, and tofu and eggs are great as well. And the kinds of fats you want to consume are oils, peanut butters, things like that are pretty good. And you want to stick with light starches and grains like potatoes, tortilla chips, and popcorn. And things you want to avoid are intense flavors like garlic, beans, and onions, uh, blackberries, watermelon, and peaches, There's some meats that should be avoided as well that are listed here, and heavy sort of foods like almonds, avocados, and pistachios, which are very calorically dense, and heavy grains as well. And next, I want to talk about chronic constipation a little bit. It's essentially just referring to decreased passage of stool. So your child may have decreased amount of bowel movements compared to what they normally do, or what you might think is normal. And here I just have a little diagram showing what chronic constipation could be a result of blockage in the intestinal tract. And what should parents look for? You might see straining with bowel movements. You might see that with your infant, they could be looking like they're struggling to have a bowel movement, really grunting and straining. You might see lumpy or hard stools and inability to completely empty the contents of their bowel, and small or infrequent bowel movements as well. Just because their bowels aren't processing the food as it should, or they have decreased passage, which is causing exacerbation, and then it builds up and up throughout the GI tract. So with chronic constipation, uh, we generally look at some blood tests to rule out any abnormal causes. It's also usually a diagnosis of exclusion and up to clinical reasoning of the physician. We can also do an X-ray or do colon transit studies to see how food passes through the stomach and the intestines. And we can also evaluate the anal sphincter to see whether the food is stool is able to leave properly. Rarely requires any sort of endoscopy or colonoscopy, and it's treated pretty well with fiber supplementation and prune juice, especially in the younger infants. Prune juice is a great aid to kind of help them get their bowel movements going. And you can also supplement with exercise and stool softeners and laxatives, fiber and suppositories. And here I just have a picture of prune juice as well as a picture of suppository being inserted, because I think it's good for parents to know, especially with the younger ones, how to treat chronic constipation. And next, I want to talk about UTIs. So they're an infection of the urinary tract, the urethra, which can be a result of chronic constipation or due to urinary stasis alone. So here I just have a picture of how chronic constipation and buildup of stool in the intestines can actually impede on the emptying of the bladder, which can cause stasis of the urinary fluids and in turn cause recurrent UTIs. And what should parents look for? Uh, you could look at lower abdominal pain is usually how it presents. They might have difficulty or pain with urination, and cloudy, bloody, or foul smelling urine can be an indication of that as well. And here's just a picture kind of demonstrating all the things we just discussed: strong odor, burning sensation as you urinate, an increased urgency to urinate as well. And diagnosis and treatment, generally we'll do urinalysis and culture, which just means collecting a urine sample from your child. We'll do an ultrasound to check the bladder and see that if it's necessary. And if it turns out to be a bacterial infection, we'll prescribe antibiotics. If there's a primary issue that's causing it, such as constipation, withholding, or vesicoureteral reflux, which is backflow of the urine, then we'll want to check that as well and treat that before moving on. And how do we prevent a lot of these conditions we discussed today? So, with the infectious issues that we talked about, I think hand washing is really important, avoiding sick contacts with people you know that have had these symptoms, and making sure that you visit your pediatrician annually and at any occurrence of severe symptoms is really important, to make sure that they can evaluate, and making sure that your child is vaccinated with the proper immunizations, like for rotavirus and other GI related um, pathogens. practicing good food hygiene and good dietary practices and exercise is also very important. Making sure you don't eat expired food and keeping an eye on what your child's eating. It's very important. And otherwise, that's about the main things that I wanted to talk about in terms of your child's abdominal pain. And here's just a list of references.
Yeah. Well, that was a fantastic presentation, Dr. Rao. I hope that your 1 month at our office at RBK Pediatrics proved to be educational for you. I'm sure you saw a lot of these cases. I think we saw every single case that you presented. Um, and, I look forward to hearing good things about you in your future. I know you're going to be a fine physician one day.
Thank you.
Even a pediatrician, who knows?
Yep.
All right. Thank you very
Thank
much.
you.